time for Q&A. Thank you. Sometimes it's a bit more of a discussion. And then in January, for example, that'll be for updates. This is hugely helpful, and we love, the Housing Is staff loves hearing what all of you are up to. We cannot possibly know everything that's going on, and so we really rely on these dedicated times to get that information from you all, and for you all to then connect to each other and have that peer learning exchange. So most of these sessions are open to anybody. Today, we are joined by non-PHAs, which is very exciting. And we also have a representative for nonprofit housing providers. Housing Is does work with non-CLAFA member PHAs as well, if you have partners that you'd like to have join us. But some of the sessions are limited to just CLAFA members, like the January one, for example. In a moment, I'll have my colleagues introduce themselves. We also will put into the chat the calendar of the remaining Housing Is working group sessions for the year, so that if you are not familiar with the upcoming offerings, you can take a look there. We hope you'll join us or share with your colleagues for whom the work might be more appropriate. We also focus on education and digital connectivity, for example. And then if you haven't seen, please save the date. Registration will be launching in the new year for the 2026 Housing Is Summit, this year taking place in Washington, D.C., May 7th and 8th, that Thursday and Friday. So in January, we will be releasing part of the agenda with all the great breakout sessions. So stay tuned for that. But in the new year, we'll be launching the early bird registration, which is, of course, the best pricing you can lock in for the event. But it's always a great time. I'm biased, but it's a really fantastic event that truly brings together partners from different sectors. So I think it's really unique. And if you've never been before, we would absolutely love to have you. And if you have been, I see some repeat customers, so to speak, joining us today. So we always love having folks back again. Okay, so I think with that, Teniola, do you want to introduce yourself?
Good afternoon or good morning, everybody. My name is Teniola. I'm the Health Policy and Program Analyst at Housing Is in CLAFA. Nice to meet you all.
And then Annalise.
Hey everyone, my name is Annalise Herr. I am the Policy and Program Associate here. Thank you for joining us today.
Okay. And as you heard, Teniola is our main kind of staff expert on health. So, since that is the topic of today's session, if there are things you want to follow up on, definitely we'll put our staff contact in the chat. But she is a great person for you to know. And Annalise keeps everything running smoothly. And in the coming months, you'll be getting emails and communications from her about the summit, as well as other activities that we're involved in. So thank you both to them. Next, I'm so pleased in a moment to turn it over to longtime partner, Andy McMahon. And Andy has really, been with us since the beginning. So he has a ton of expertise. I'll let him introduce himself further, but really pleased that he was able to join us today. We've, as I mentioned, worked with Andy for a long time, starting from when he was at Corporation of Supportive Housing to United Healthcare to now Health Management Associates. He brings really a unique set of experiences and expertise looking at these issues of health and housing. And we're going to be talking today about ways that housing authorities and nonprofit housing providers can be working more intentionally with health partners, in particular health centers or health payers. So I know that this is something that some of you are already engaged in. We'll be really excited to hear from you as well. Definitely want this to be a discussion, to get input from you all, hear what's working, what's been challenging, questions that you have for how to make ideas you might have work. I know this has been a difficult year for everybody in terms of funding concerns and instability and where to focus your efforts, particularly if you're a houser. Sometimes, even though we all know how integral all of the cross-sector work is, sometimes it can be hard to do when the very foundation of your mission to house individuals and families is really being challenged. So I will leave it at that. But again, so pleased to have Andy join us today and excited for you all to have this opportunity to talk with him. Andy, do you want to introduce yourself further?
Sure, great. Thanks, Abra. So I will do a quick introduction, Abra, and then kind of turn it back to you as we think about the conversation and questions folks have. But Abra and Claffa team and all of you guys, thanks so much for the invitation to join you all. As Abra mentioned, I've been a longtime partner with Claffa in a number of roles, and I would just say. In large part, I'd like to think that's strategically because of the enormous value and opportunity that there is to partner with public housing agencies and to better support the health and health outcomes of hundreds, if not thousands, of residents that you all have the privilege to provide, whether it's rental assistance through Section 8 or public housing too. So just want to start with a note of gratitude for the amazing work all of you guys do, and as Robert mentioned in particular, a pretty tricky year, but we will persevere together and in partnership. So, Andy McMahon, I am a principal at Health Management Associates. We go by HMA, generally speaking. I've been here coming up on 1 year. And came over to HMA and am delighted to be here and the focus of my work is really working with a team of people, including Tia Cintron and a host of others, to build out kind of a health and housing and cross-sector practice to our work at HMA. HMA has been around for 40 years now, and essentially entirely a public health care, largely Medicaid, but public health care consulting firm with about 1,000 people all across the country. And just to note, because I think it actually really is pertinent to the conversation as we go down the road, is that HMA is largely made up of people who have been in the healthcare hot seat, right? These are not folks who are just kind of saying, "Oh, we'll try this or try that." It's made up of a whole host of folks who have been state Medicaid directors, hospital CEOs, health system CEOs, other C-suite folks and experts across the entire healthcare spectrum, I would say. And so over the course of the last year, we've been doing a lot of work and partnership building, including with you fine folks at CLAFA, to think about ways in which uh, the healthcare system writ large, but I'm going to say more specifically, health systems, hospitals, et cetera, can better align and connect the dots with you fine folks in the housing world. So excited for the conversation. Just as background, Abra mentioned a little bit prior to joining HMA, I was at United Healthcare. Community and State, which was the Medicaid organization within United for several years, and then spent a bunch of years at Corporation for Supportive Housing, CSH, as well. So excited for the conversation with you all today, Abra and team.
Great. Thanks so much. Okay, so I'm going to turn it over to Taniola, and I think she's going to kick things off by asking some questions of everyone who is on. So please feel free to unmute, put some stuff in the chat, raise your hand. But I think we want to get a sense of kind of where folks are, what you may already have in place, just to make sure we have the right context to start today's conversation. Taniola?
Thanks, Abra. So yes, I would like to just first ask everyone on the call has anyone engaged and been involved with working with a hospital or health center, or any health payers to provide on-site health services to your residents or the population that you serve? If so, can you elaborate on your relationship with the hospital or the health center, and in which ways has they helped you support your residents too as well?
And feel free to do like a thumbs up reaction or raise hand feature. Okay. Thanks, Dominica.
I see Kelly unmuted, so
Yeah, I'm trying to figure out how to raise my hands on this. Yeah, it's easier than to try to type it into chat. We have worked with our local systems um, in a variety of capacities. We did. Do you want me to just stick to current, like what we currently have going on, or historically what we've done?
you can do both current
Okay.
and briefly
Okay,
past.
okay, okay. Super quick. We were part of the community health worker project that HUD did back in 2022, um, with Akron Children's Hospital and worked in that project. And then they also come to some of our events here and do things like asthma screenings, help the families sign up for services. They've done some physicals on site. And then Cleveland Clinic Akron General has, oh gosh, they've come and done, talks on like diabetes education, different topics, as well as coming to resource fairs to share information on like their home-based services, um, etc. And most recently, they have a community health worker that's going to be on site once a week at our Reach Opportunity Center. So we have worked kind of collaboratively with a couple of the systems.
Hi, I just wanted to add, we in Oakland have done something similar. We have nursing students from Samuel Merritt Nursing School come in on a regular basis and host an on-site basically clinic where they do testing for, A1C, and they do blood pressure checks and sort of non-invasive procedures to help the seniors in particular, but anybody who really walks in the door at our East and West district offices, and they do that once a month at each site. And we also are trying to work with them to have someone stationed there a little bit more regularly. But we have that ongoing partner. That partnership has been in existence for a really long time. And then we have a partnership with the hospital, but it's not necessarily on site. But I thought I'd mention it, where we are partnering with UCSF Benioff Children's Hospital. Oh my goodness. To provide housing assistance to referrals that they send us. So we will provide the housing assistance. The hospital will provide the referral, and then our grant partner funded us to pay for services for those families who have children in the ICU, so in the NICU or the pediatric ICUs. And that partnership the MOU is getting signed this week. So we hope to launch it and be able to provide some housing supports to families who are going back and forth to the hospital a lot. And all of the units are near the children's hospital. So that's the two partnerships that we have existing with our hospital healthcare partners.
Thank you so much for that, Kelly and Dominica. I'll go next to John.
Hi, good afternoon, folks. John Kane with the Boston Housing Authority. I was going to mention three, so I'll just try to very briefly say, but and for the longest one is it's called Breathe Easy. And so essentially, if somebody comes into a hospital or health center in Boston, there's a triage question, which is there some factor in your home which is affecting your asthma? And then that would be linked to the inspectional services department that would then go to that person's home to see if there's a factor affecting their asthma, such as pests or mold. And so BHA has been a part of that, and it's a way that we try to get upstream a little on asthma incidents in Boston. The second one I would mention is the CHIP, the Community Health Needs Assessments and the Community Health Improvement Plans, which is a part of the Affordable Care Act, so that when nonprofit hospitals, they do a needs assessment of the community, and then they put money into grant opportunities that very often are, trying to serve or factors that affect social determinants of health. And so BHA has really competed, for the last 10 years in that area. And we've also been on part of the, helping to get our residents to participate in the health needs assessment. And then the third one, and just on, and this is new for us, is we're working with the Boston Medical Center. And it's actually one of the criteria. There had been a Medicaid waiver so that the Boston Medical Center and their health insurance plan can do some housing navigation and case management services. So they still can't help really pay for rent, like that's a different pot, but they can help families that have housing issues, such as a lease violation for being behind on rent. So that's a new program for us here in Boston. Thanks.
Thank you, John. Next to see Biljana.
Hi, everyone. Biljana Jessic, here from Portland, Oregon. As you can see, I'm still drinking my coffee. It's only 11:20 over here. Officially still morning, right? So I think I would highlight maybe a couple of things. I think someone earlier mentioned, just a relationship with student nursing program. This has been really amazing for us, especially our high-rise properties serve a lot of folks who are seniors and folks with disabilities, and that relationship has been really important. In addition to like mobile clinics and, really trying, to kind of think creatively, how do we provide services on site in our properties? Because we know that that's, some of the challenge, for folks. And I know that like digital inclusion is also a really big piece, that Papa works on. And for us, we've been focusing a lot on making sure that folks that are specifically medically vulnerable are connected to devices and services. So for quicker access to medical services as well. So a lot of intentionality to sort of like holistically look at how do we remove barriers, to connect folks to services. And for the last 12 months, we have been actually part of a pilot program here in Oregon. It's called 1115 waiver, something similar to what John talked about, which is basically pairing services between housing and medical insurance, and figuring out ways, how to fund our staff to provide services on site and holistically connect folks to anything essentially that's related, to housing and social and health needs. I can drop a link in case folks are interested in reading a little bit more about it. But we've been participating in this pilot and are learning a lot about sort of cross-reference between health and housing. How do we best provide services to folks, again, from that holistic perspective? And our funding resident services coordinator and a case manager who are essentially connecting folks with these important services in the community. And we're seeing a lot of great success, by stabilizing, housing and connection to social service needs. Then how do we also address, some of the health barriers? It's been a really good partnership for us. And so, we're still learning a lot, but are definitely hoping, that we continue to develop these kind of models. Frankly, for housing authorities, it's a great partnership to continue these relationships.
Thanks so much, and I'll kick it over to Christian.
Hi, this is my first meeting. I'm filling in for my manager, George Silva. But I feel like I wanted to just mention, I'm with the Housing Authority of the County of San Bernardino. We do have a lot of partnerships and a lot of ways that we partner with the medical community, but one in particular that came to mind that no one kind of shared, we hold a spot at a community resource center up in the high desert, where San Bernardino County is huge. So we have a lot of different area to cover. And we have a housing caseworker or like a housing specialist inside, and IEHP would be kind of like our Medi-Cal. They're connected to Medi-Cal. And so a lot of our clients are receiving their health services through that. And so IEHP is one of the providers of those services and the medical services. And they have a community resource center where they also have employment services. They have options for like learning cooking classes. They have yoga, things like that. And it's all within a resource center. And so the Housing Authority actually has an MOU with them as a partnership to have an office there on site. So anyone coming in to receive certain type of health questions, health services can then also go speak to someone that's providing also their housing choice options. So it's a really great partnership. We're opening a second resource center and partnering with them currently to do that as well.
Thank you so much for sharing and also welcome. Thanks for joining us today for your first meeting. And I just want to say thank you for everyone who participated and said something. And I think you guys are doing such amazing work for the residents, whether that is utilizing your Medicaid 1115 waivers to center towards housing support, or working with nursing students or their school of nursing just to be able to help residents too as well. So next, I want to definitely ask Andy a few questions just to get his expertise, and also if there are some of you on the call who do not have any partnerships with hospitals and health centers. Andy could be a great resource for you to start thinking about cultivating those relationships, or let's say you already do have a partnership. How do you continue to build upon that? So Andy, I would love to ask you the first question, as well as what partnerships have you also worked in yourself involving a housing provider or a hospital or health center? And then what lessons did you learn during this process?
Sure. So first of all, huge shout out to all of you guys. I mean, there's some people doing some amazing work. And when I was just looking at my little bullets that I wrote down to your guys' questions, and folks mentioned some of those already. So kudos to all of you guys, and excited for the conversation. So Teniola and team, I think I'd highlight briefly just a couple of examples, and then really focus on kind of some of the lessons learned and the like, and then keep the conversation going, and questions and back and forth. So a couple of entities where I have worked with, and through HMA and in past lives with health systems and housing groups, is with Fairview Health System. Is a large health system in kind of the St. Paul, Ramsey County area of Minnesota. And I know one of your members of the St. Paul PHA is there as well. And Fairview has done a couple of things that we worked with them on. One was actually a kind of an infrastructure, creating a health hub that is actually in close proximity within a handful of blocks of a number of St. Paul PHA assisted buildings. And so currently working to think about kind of connectivity, and creating partnerships between not only Fairview Health Services from a behavioral health and primary health perspective. And some of it, I think somebody mentioned having kind of CHW, community health worker, somebody else, visit various public housing buildings. And it might even be one day a week for a morning, 9 to 12. But that, especially as you get that word out, that kind of ability to connect people to care, I think is really critical. And then in additional, with Fairview Health, they also, as part of their health hub, had built out essentially a pretty robust food shelf and an emerging employment and training component to it. And so thinking about where the synergies between people living in St. Paul PHA, assisted housing, and partnering that and connecting them to Fairview, again, whether it could be, it's I think, primarily thinking about primary and behavioral health, but also then thinking about food insecurity, employment and training, and the like. And another I would mention is in Austin, Texas, working with the Central Health District there, and St. David's, and a couple of others. On initiatives, and kind of connecting the dots between healthcare and housing. And I think, the Central Health District include, is a kind of an odd duck for a kind of a health system that's kind of publicly owned, in large part, kind of quasi-governmental. But at any rate, again, thinking about creating those partnerships and linkages. And I think one of the things that I would say to all of you guys is, and I think a number of folks have already done this on the phone, and if not, but is honestly the initial outreach. And in both of those examples, I think some of it was like, okay, well, I haven't talked to these folks, but like, why, kind of why should I, right? What's in it for you as a public housing agency, or what's in it for you as a health system? And so I think, from that perspective, I think that honestly, just that initial outreach to start it is so important, because in my experience, in those couple, but also in a number of others, is you each entity recognizes in maybe in an ideal case through data sharing, which I think we'll talk about in a bit, Teniola and team, but also just in understanding the populations you serve, that the intersection between people living in publicly assisted housing in a community and people who are needing substantial levels of primary and behavioral health care and other supports, the overlap is large. And so I'll just say, in my hometown of Minneapolis, I know a few years ago, MPHA had done literally a data match and looking at folks who are in MPHA assisted housing and people who are on and or eligible for Medicaid. And I want to say the overlap was in the 89 to 91% range. Now that is an expansion state. So just to be clear that is an important caveat. If you're a non-expansion state, clearly those numbers would be lower. But even thinking about that data and as kind of as lessons learned, as you think about, well, why would I work with, why would this health system work with me, or why would I want to work with them? Is that either you can do your own data, or you can look at data that's out there and recognize, and even the characteristics of your shared populations, and realize that the likelihood that the people you all are providing housing assistance or public housing to, and the people who are going in and out of the emergency room or acute care settings, or not getting preventative care that they need, is huge. And so I think that's a really big driver, I would just say, in terms of kind of the motivation, right, for each. You guys got a ton going on. Everyone has a ton going on. And so thinking about, oh, there's actually a value proposition for me as a PHA, or me as a health system or hospital system, to engage, to better connect, for you all to better connect your residents to care. And on the health and hospital side, to better manage and hopefully reduce the number of people who are coming in for emergency visits or acute visits, and increase the care, right? So this is where care utilization is a positive thing, increase utilization for preventative care and other kind of connections and supports. A couple of other things I would mention, Tenniel, and then we can go wherever you would like, but is also, I think, understanding, and Abra, huge kudos to you and CLAFA, because I know you guys do a lot of this. So, but is kind of the understanding the language barriers and translations, that, right? Folks speak different languages. That doesn't mean you can't work together by any stretch. But is kind of, I think, understanding not only, you're never, you don't need to know all the healthcare acronyms, and they don't want to know all of your PHA acronyms, but having kind of operational ability to work together, I think is really critical. And related to that is also understanding kind of where you guys have capacity and opportunity, and where you have constraints, and vice versa for the health system, right? And I think one of the things that I would just highlight, Abra, and some of our past work together, and then, even going forward, is understanding, and I know Teniola has a question about this later, but around like data sharing and other things, and recognizing the prohibitions that HIPAA has. So like if you do a data sharing agreement, it's not that the health system can then share all sorts of data back to you. So there just unequivocally is a kind of an asymmetrical relationship there, right? Where like they may be able to then have a whole host of health data that the PHA is not privy to, and that's because of for good reasons. But I think it's so just understanding the various not only the languages and the constraints. I'm sorry, not only the language, but also some of the both statutory, regulatory, and also administrative constraints that folks have. So I guess that's just a few ideas off the top, Tenniel.
Thanks so much, Andy. And I definitely did want to go to that question around data sharing. So, as you mentioned, like, in what ways can the data sharing process between PHAs and other housing providers and also healthcare partners become more seamless? And I would love for anyone on the call to also jump in just to explain what their data sharing process is. And yes.
Yeah, so I'll go brief, and then if anyone, please kind of raise your hand, or I guess I'm sure Teniola somebody watched, but if other folks have kind of gone through this, would love to hear other people's perspectives as well. But I think, from my perspective, having done quite a bit of work, it's challenging in this kind of health and housing data sharing, both with PHAs and also with continuums of care. But I've done a good amount with PHAs, including work with ABRA, is understanding kind of I feel like the couple of biggest things are understanding what data you all are open to sharing, even in a anonymized version, so anonymous data, because you're really trying to understand what is the cohort of people, not necessarily at an individual level, right? That's where you come up with some of the HIPAA challenges. But so I think thinking through the types of data that you can share, right? So what, just to be candid, what's kind of the minimum or a reasonable amount of data that you all could share that could then be, not give it, but at least be able enough to say, okay, well, here's how we can kind of connect and see the overlap between the two. And then I think really, really importantly is understanding, and I say this some from past experience, of understanding kind of how that data gets used, right? And I think and being clear on that between the partnerships, in my opinion, has been one of the biggest things to ensure happens. In my experience, you guys, I think there is certainly, when you think about the data sharing component, and this is probably my primary comment on this, Teniola, is that there is unequivocally issues, technical issues to figure out. Like, what fields are you going to share? How are you going to transmit this so it's encrypted? And how are you going to do all of the technical things that are necessary? That said, I will tell you the appropriately so, the biggest barrier I've experienced when it comes to data sharing is the development of trust between the partners, and understanding that there's an agreement that, hey, here's how we are in this endeavor together. Everyone may not have equal access to kind of, the information, but being clear on how data will be used within the partnership in a way that is conducive and beneficial to your PHA residents, I think is really critical, because I think, appropriately so, having worked with PHAs, COCs, and others, a lot of times like, well, hold on, why would we give this to you? What are you gonna do with it, and what's gonna happen next? And so I think that, Teniola, and all of you, is really key to ensure that, yes, you absolutely, and I went through it painstakingly in terms of the encryption and all those things that are really critical from a technical perspective. But from a partnership perspective and sharing and partnering, I think the really important thing is building that trust and having a strong and solid shared sense of, as the data sharing happens, kind of what can each of the partners expect and what can they not expect to get from it.
Thanks, Andy. Oh, go ahead, Robert.
No, 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 no. This is great. I was just gonna pause and say, I wonder if this would be a good opportunity to maybe hear from some of you about some questions you have around what Andy's just been talking about, or if you want to share about your own experiences. I know we've spent a lot of time over the last many years talking about data sharing, some of it from the education side, but a lot from from the health side as well. So wanted to just take a moment and invite folks to share on this topic.
You know, some people are doing some good work out there, Opera.
Do too. And I think also I would just encourage folks to think about, Andy mentioned this, and you've heard me say this many times over the years. It can be a really lengthy and frustrating process. Sometimes your legal counsels want to get involved. There can be a lot of potential barriers or perceived barriers, as well as actual ones. So if you want to share about challenges you've had, I think that can be valuable as well.
Folks, please jump in. But Abra, I think that's so right. I talked a lot about trust. The other part is the expectations, right? Of understanding how quickly this can happen. Auburn team, I can recall talking many times with your outgoing or maybe gone executive director Sonia Zaderin, that like you do have to be in this you have to be committed to it, right? This is not a super quick win and let's move on, right? So just to be very candid, there's an amazing amount of work that can be done if you do this, but this is not a quick win scenario by any stretch. So good point, Abra.
Well, I'll jump in again, but again, now I am coming in with a little, not limited knowledge, but newer to understanding our partnerships at our housing authority. But I do know we have a long-standing partnership with Loma Linda University. It's a local research hospital out here where we're at. I want to say our partnership's been over a decade now. And the sharing of, we're an MTW agency. So we have a 5-year timed housing program, and they took some interest in that as a research hospital and wanted to start obtaining more research as far as like a self-sufficiency matrix and running that and submitting those results back to them. So we do data sharing in that way, but it's probably more on our end. We're passing a lot of information back to them because they're trying to do some linkages, I believe, with housing stability versus self-sufficiency and health, and kind of creating that research. And then I also know that we follow up with our participants as they exit our 5-year program, and Loma Linda, the hospital itself, sends out a survey, 1-year post and 2-year post after their housing has turned. So once their housing expired after that 5 years, they want to see how those participants are doing, how their health is, where they're overall in their journey, their life. So I know we have that partnership, and it's a pretty solid one, but I do know it took a long time to build, to establish trust, to say who was going to share what. I know our MOU updates often. But like you said, with trust, I think now that has been established and built after that long of time, and we're both for the same end result. And so I think when the why is always communicated, like you were saying, if we're always saying the why is we want healthier, thriving families, we want families housed, we want them safe. And so when we have that end goal, the partnership seems to thrive better when we keep having that conversation. So I do know that's one of our partnerships.
And as other folks are thinking of jumping in, so Kristen, thanks so much for sharing that. And I think, and I don't know if I mentioned it yet, but I think that kind of MOU part is so important. And I would say whether or not you're doing data sharing or not, even if you don't do data sharing and you're thinking about the roles, that just goes to the expectations and what's going on. Okay, it doesn't have to be a 20-page document, but it does just have to say, hey, here's the things that the PHA is going to commit to do. Here's the thing the health system's going to commit to do. And here's the thing that both systems are going to commit to do. Right? So it doesn't have to be rocket science, but I think kind of clarity of roles and expectations, Kristen, to your point, I
And
think
they
is really
change and
important.
grow, right? So as
Yeah.
you're finding more trust with them, you grow and you learn and you rewrite the MOUs and add and subtract. So yeah.
And yeah, I'm Kristen with the King County Housing Authority, and I am still relatively new, so still learning sort of all of the systems and processes. And I wanted to share one of the things that we're really thinking about in the context of data sharing agreements is also the release of information that residents are signing, and how does that fit into the share of the data? And so we've been having a lot of conversations internally about what has been authorized to share and for what purpose. So are we doing evaluation type of work around a particular programming, or is it something that's more health surveillance? And if it is more surveillance, is that an appropriate share of information? So we have a data sharing agreement with our local public health agency. So what does that look like? And do we need to clarify language in any of the release of information documents to be able to feel comfortable in that relationship with public health?
Yep. I love it, Kristen. Thank you.
And I wanted to get into our other question because Liliana mentioned earlier utilizing Medicaid 1115 waivers has to help with housing support. So what I was thinking about is what are other funding sources that PHAs and other housing providers can utilize if they do want to, have more health-paced initiatives on site or just working with hospitals. So do you think it's like working with a health planner or also finding other grants? So what do you think, Andy?
So I think so. So thank you. I mean, I would say, and it seemed like just in hearing folks talk before, there are definitely folks who have leveraged 1115 waivers, and kudos to you all. Whether it's through so I think oftentimes through kind of tenancy support types waivers that CMS approved several years ago. But I guess just so I'll mention a couple of things. So one on the kind of waiver and the kind of Medicaid front, very specifically at the kind of Medicaid agency level. I think it's just important to know that I think 1115 is probably oftentimes the most popular way to do it, and in a way that a lot of kind of a go-to way to get a waiver to do something that Medicaid otherwise wouldn't let you do. So it makes a ton of sense. And we don't necessarily have time to go through it all now. So Abra and Tenniel and others, I'd be happy to do follow up with anyone interested. But it's also just to know that there are also 1915I waivers, which is another pathway if 1115 doesn't work for you. I think 1915I is Byzantine, I know, especially when I add a lowercase vowel to it, but is I think a really another kind of alternative, and I would also say something else called state plan amendments, spas in the Medicaid land is another way. So I won't dive into those given time today, but just to know that 1115 is a primary way, but it's not the only way to think about kind of getting access from a state Medicaid agency perspective. There are a minimum of two other ways, and probably others who are more creative than me, but there's a few. And the other thing the other two areas, Teddy, on these, I think can be in combination, either just provider only or health system only, or in partnership with a payer. It can be either or in many cases. But is thinking about the two other areas I would think about. One is called in lieu of services, ILOS. And so those are things that a health plan and providers can work together on to provide to people that they're serving in the health system, and saying, okay, well, in lieu of doing this, we're going to do something. I mean, it's a little Byzantine, I know, but the notion behind it is in lieu of, instead of paying for this that is eligible for Medicaid, we're going to use those dollars to pay for something else, but it's going to have the same impact. And so, there has to be some, I think, veracity to that for sure. It doesn't have to be, triple blind evaluations, but being able to talk about that. And then the other is thinking about partnering with both health systems and payers on value-based care contracts or payments, VBC arrangements, where plans and systems can work together to say, okay, we're gonna we're gonna have a contract with this PHA and here or the between this health system and the PHA, and here's the outcomes that we expect to see. Here's the value in what we see being created, and then creates greater flexibility in terms of what those actual services are. And so those are, I think, the two primary ways, in addition to the three or four ways to think about accessing directly and kind of the state Medicaid folks blessing it and saying, okay, here we are, this is, okay. The other two venues are working with payers and health systems on in lieu of services and value-based care arrangements.
Has anyone worked with in lieu services or the value-based care contracts? Anyone? And that's okay. Um, so thank you so much, Andy. It's always good to learn what other funding resources people can think about, or, working with the partners, either the hospital or health center, or even a health plan. Just think about the other sources that they could use and utilize. And one of the questions I'm also thinking about is what we're always thinking about is sustainability. So how do we continue to keep these partnerships with hospitals and health centers and how do we maintain it? So one of my
Yep.
questions is like, what do you think are some long-term strategies or what would you recommend for PHAs and housing
Sure.
providers to do to maintain, either have on the on-site health services or just continue the partnership with working with
Yeah.
health
So
centers and hospitals? Mhm.
awesome question, Daniel. So I think there's a few things as we think about sustainability. So one is, and I'm going to say this without trying to kind of over fill the apple cart, but is to think about the extent to which you can track kind of outcomes that you're having. So if people can see, okay, we've created this partnership, and maybe not, it's, I'm not saying some, randomized sample type of thing, but can you do just some even fairly elementary tracking of like, okay, what is the, where were we? And it doesn't necessarily have to be too, I mean, if you can do it to a health outcome, wonderful. But even if not, you can say, okay, well, we were able to connect these folks to care and those sorts of things. I think people being able to see the results, right? I mean, is I think one core way. And while that seems obvious, I think, right, it's really hard. It's oftentimes not, doesn't happen. And so I do want to highlight that the extent to which there's opportunities, even in a more elementary sense, to think about uh, being able to track outcomes, at a fairly basic level, makes it something that people want to continue. The other is just to keep in mind, and I know we're living in a crazy world overall. In the housing world, you guys got it. In the healthcare world, we have massive Medicaid cuts and all sorts of other things as well. Um, and work requirements coming in, all the stuff. I get it, and I'm not trying to, trust me, I am not trying to sugarcoat any of that. It's pretty, really, really awful. That said, the extent to which people meet the eligibility requirements for Medicaid, they are eligible and it's an entitlement, right? I mean, that's getting batted around because they're basically trying to reduce the number of people who are eligible, candidly, even as they think about redeterminations, doing them twice a year instead of once a year. There's a lot of efforts, just to be candid, to try to reduce the number of people are eligible. But right, is to just keep in mind when people are on Medicaid, unlike you guys who in the Section 8 in the public housing world, right, there is no entitlement, right, as you guys are painfully aware. But there is in Medicaid, right? So I think, Teniel, that's a really important component was when we think about the sustainability component. And then the other thing I would say, and I'd be curious if anyone on the call has had this experience, is also working and partnering with sometimes city, but depending on your state, more often than not, county human services and public health agencies. And Abra's, I see you nodding, so I'm sure you guys do some work with that. But honestly, kind of county public health or county human services, sometimes people think like, well, that's kind of in the middle somewhere, right? Like we're housers and these people over here are the hospitals. Like, human services and public health can also oftentimes be the kind of glue that makes all these things fit together, I would say. And and it's not like counties have a bunch of money, but most counties do have grant related programs, if not specifically for this, for things that are akin to this. So as you think about sustainability, it's also thinking about who else has a vested interest in supporting these types of efforts.
I think there was a question in the chat, Taniola.
Yes, from Amy. Have we seen any housing related in lieu services approved under the administration? I would say from my standpoint, I have not seen anything. I think the more I've seen is like Medicaid 1115 waivers, but that has been really slow for in terms of CMS approving the Medicaid 1115 waivers, but I have not seen much traction on in lieu services. What about you, Andy?
So, hello, Amy. I know Amy very well, and Amy can be the one to correct me as need be. But Amy and all of you all, I'm actually not certain. I'm actually not certain. I don't think by and large. I mean, I think at the provider level and this level, I don't think you necessarily if you can work with your state Medicaid agency, Amy, please feel free to correct me. I'm wrong plenty. But I guess I don't believe that in a lot of cases you necessarily need CMS to approve an ILS waiver if you can get the state Medicaid agency to approve it or to say it's okay.
Oh, okay. I didn't know. I know Nevada is like the only state I've heard of that has an approved in lieu of, and I know they had some back and forth with CMS, but I don't know what what it was related to.
Totally. Yeah, so Amy, let's follow up and honestly, Teniola and Abra, I'll make sure to connect with Amy and others and clarify that for you guys because I guess Amy, yeah, and I'm talking to Amy, I think soon, but is to think about whether or not that's part of kind of a negotiation and they wanted that in there and it's part of like a package of things that they have as part of an 1115 or
Oh,
something else
could be.
versus somebody saying, okay, well, we have the parameters, within our existing state Medicaid agency, but that again, to Amy's point, is state specific, right? So any states don't have, I mean, at a core level, they have the exact same set of, at the very, very base level, when it started, they have the same level. But I mean, over time, lots of them have layers and layers of things that they're able to do.
Hmm.
And so if they're doing it earlier on, they may have gotten it. And unless CMS came and said, now you can't do it, they already have the ability to do some of that.
Okay, interesting. Thank you.
Yep.
So I do want to just flag, I know we're coming to the end of time.
Yes.
So if you have other questions that you want to ask Andy, now is absolutely the time to come off mute and do
And
so.
also, Abra, feel free to add my contact information, or if you send out a recording or anything, I'm happy to connect with folks.
Okay, will do, definitely. But yeah, if folks have questions now, while we do have Andy, he's very gracious with his time, but scheduling can always be difficult. So
Well, that's true too.
and Teniola, I'm sorry if I cut you off if you were about to say something.
No, I was just about to also wrap up too, and I wanted to thank Andy. So thank you so much for joining us and answering the questions and providing your vast knowledge. And I also wanted to thank everyone else who joined the call too, as well as providing your input and things that are going on at your housing authority, and just also things that you're doing in terms of the health work. I know that it's very difficult times for everybody, and but we again appreciate, and also I am really interested and engaged in continuing to learn what you all do. So thank you so much. And it's been a great conversation.
Yeah, thank you all for the invitation and kudos to all of you guys for the work you're doing around in this space. And I, hopefully Aubrey and others can vouch for me. I've been worked with you fine folks for 20 years. I am enormously grateful for the work the PhDs do. So thank you all. And like I said, happy to connect with anyone offline as well, Aubrey and Teniola.
So much.
Thank you all. Have a good day.
Thanks, everybody.